on the subject of surgery. My name is Antonia Sinclair. I work for Clapper as the Community Engagement Coordinator, and I've been with Clapper for about a year now. So today I'm joined by Bronwyn. Bronwyn, if you wanted to introduce yourself.
So I'm Bronwyn. I was born with a bilateral cleft lip and palate. I've benefited from Clapper services myself when I was a lot younger, and then I started volunteering for them about 2 or 3 years ago now. So yeah.
Fantastic. Thank you so much, Bronwyn. So today's session is all about surgeries that someone may have during their cleft treatment journey, starting with repair surgeries all the way through to jaw and reconstructive surgeries. We're very pleased to welcome cleft specialists Mr. Alex Cash, Mr. Peter Hodgkinson, and Dr. Amy Puddock, who will be answering your questions this evening. So Alex, Peter and Amy, would you like to introduce yourselves as well?
Hi, I'm Alex Cash. I'm a consultant orthodontist. I've been involved in cleft care since 2000 in a significant way, and then I've recently been the clinical director of the cleft service in Southeast England, and I'm a consultant orthodontist at both St Thomas's and also in East Grinstead.
So, hi, I'm Peter Hodgkinson. I'm a cleft and plastic surgeon in Newcastle upon Tyne. I've been clinical lead of the cleft service there since 2002 and involved with clefts for a long time. I'm a previous trustee of Clapper. That's me.
Hi, I'm Amy Puddock. I work at the Welsh Centre for Cleft Lip and Palate as the consultant lead clinical psychologist there. And I also work at Cardiff University as a senior clinical tutor on the South Wales doctoral programme. And I've been with the team. I'm quite a newbie in the team. I've been working with the South Wales team since February, but I've worked in children and children's health services for 15, 20 years.
Thanks so much, Amy. And we're also pleased to welcome Jo, our Clapper volunteer. She's a parent volunteer. Would you like to introduce yourself as well, Jo?
Hi, everyone. Apologies for the delay. I had some technical issues. Yeah, I've been with a Clapper volunteer for well over 11 years now. I'm a peer volunteer and I do the coffee evenings, shall we say, meetings, and yeah, that's me. I've got a son that's 16-year-old with a bilateral cleft lip and palate.
Thanks, Jo. Excellent. So thanks everyone for that. We've had some people submit some questions in advance of the session tonight. So if you have a question whilst you're watching, then please do feel free to pop it in the comments section, and someone from Clapper will either respond to you directly on the chat or pass it on to us. Do feel free to also share your own personal experiences and just join in the conversation with us on the Facebook chat. Right then, on with the questions. So before we start, we're going to ask for each different surgery that we talk about. Our specialists here are going to give a brief overview of each topic. So our first area of surgery is lip and palate repair. So Peter, would you be happy to just give us a little overview of that?
Yeah, that's grand. I've got a very good feel of surgery across the different centres in the UK, although so there'll be minor differences. I'll talk about how we do it in Newcastle. It'll be similar mostly elsewhere. We like to do a cleft lip repair. It's about 3 months of age. That's often combined with a vomer flap, which is a repair of the front of the hard palate. Cleft palate surgery is designed to happen before 12 months. Some centres do it at 6 months. Some centres do it nearer to 12 months. Both surgeries involve not only closing the gap, but also moving the muscles so that muscles can function in a more effective way.
Excellent. Thanks so much, Peter. So, Jo, I think, did you want to start us off by asking question 1 for us? You got the, not to worry if you haven't got the questions there, I can.
I'm having problems with my opening it up. I'm having
Not to
problems
worry.
technically. I'll get back to you.
That's all right. I'll kick off with question 1. So question 1 that we had submitted was, my daughter is having palate repair and has Pierre Robin sequence. What does recovery look like? What are the difficulties in managing pain, length of recovery time?
Okay, so PR sequence happens when there's a cleft palate and a relatively small lower jaw, and often associated with breathing difficulties, particularly with younger babies. Generally, we would aim to organise a palate repair at about the same age, but sometimes in children with PRO sequence, it's delayed because the jaw is so small. The operation, I think, in general, looks much the same as a normal palate repair. The potential difference is that in closing the palate in a child with PRO sequence, this can narrow the airway at the back of the throat, and there's more likely that post-op we might insert a nasopharyngeal airway. This is a very soft tube that goes through the nose to the back of the throat. Children with PRO sequence have often had this as babies anyway. That's in for a short time while the palate is swollen, and then it usually comes out before discharge. As far as pain, that's managed in the same way as with the cleft palate repair. Many of us put in local anesthetic blocks both in the palate and into the nerves within the face. Recovery time is often the same as with a cleft palate. Children who've had a cleft palate repair strangely find it harder to take fluids than they do to take solids. So you'll often find that taking fluids is a bit slow. So certainly our nurses in Newcastle mix up really sloppy Weetabix, and babies start on that. And then with support from the cleft specialist nurses, babies are encouraged to take fluids from a cup. I don't know whether that answers the question.
Thank you, Peter. If anyone else has anything to add to that one, you're more than welcome. Not to worry.
If not, we can move on. So the next question is, my daughter has quite a large cleft, and we've been told there's a chance that it could reopen. So I was just wondering if what this would mean if it were to happen in terms of development, so speech, feeding, further surgery, etc.
Okay, I'm guessing again that this is a large cleft of the palate as opposed to a large cleft of the lip. Clefts of the palate come in lots of different sizes. They can be quite narrow where the palatal shells are almost touching, or they can be quite wide. In general, although there's not a lot of hard evidence to support this, the wider a cleft, the more likely it is to heal with what we call a fistula, which is where there's a residual hole in the line of the cleft. Often it's the point where the soft mobile part of the palate meets the hard immobile part of the palate, because that's where everything's tighter. That fistula rates vary in different clefts in different centres. Many people look at a fistula rate of about 10%. As I say, as clearly you've been told, with a wider cleft, that's more likely. Often, it's not a problem at all. A small fistula sometimes can be left and not be a problem way into adulthood. A larger fistula may occasionally affect speech. Very rarely feeding. Feeding, sometimes younger children can leak some food down the nose still after a palate repair. Often it's sticky things like chocolate and milk that get stuck to the roof of your mouth and get pushed through with the tongue. Your cleft team will talk to you about further surgery, whether it's helpful for speech to close the hole, or whether it's one of those things that can wait.
Thanks, Peter. I think I'm going to hand over to Joanne to carry on with the questions now.
Finally, sorry about that. During repair surgery, how is the gap filled in the lip or palate when the cleft is very large?
Okay, that's a really good question, and I get asked that a lot. And clearly I'm a plastic surgeon, and one of the things I get asked is, well, what sort of plastic do you use? And we don't use plastic at all. We call plastic surgeons for the same reason that plastic is called plastic. Plastic in ancient Greek means moving things around and changing the shape of them. So plastic is called plastic because it's something you can change the shape of, and plastic surgeons are called plastic surgeons because they change the shape of things. So for a lip, the way that the gap is closed is that we mobilize the tissues on either side of the gap. We free off the attachments of the abnormal muscle attachments, where the muscles of the lip are attached to the bone of the upper jaw, where the tissue inside the lip is attached wrongly to the gum. And we free that off, often way out over the cheek. So some of the babies that I operate on with wide cleft lips have black eyes, because we've freed up the tissues on their cheeks way up out laterally so that it'll slide across and move. Occasionally, if there's a very big gap in a cleft lip, particularly if it's a bilateral cleft lip, some of us will do a technique called a lip adhesion, which is a sort of preliminary operation where we stitch the edges of the cleft together so that it stretches and pulls everything into line. And at the time of palate repair, we do a second operation when everything's lined up so it's easy to join together. For a palate repair, it's a little bit easier to understand. So there are three things that help us with a palate repair. I'm going to try and get my hands in the frame so it works. You cut along the edges of the cleft, and sometimes the gap is so narrow that it will just, get my hands in, it will just stretch and come together. The next thing that helps us is that the palatal shells that are pointing upwards, and when you free the layers off, the layers drop down like a drawbridge and come together. So that's the third thing that helps us. And if it's still not meeting in the middle, we make some cuts next to the gum, which are called releasing incisions, and that means that the soft red tissues of the palate can slide together into, so I get my hands on, slide together into the middle, leaving gaps at the side, but where there's bone underneath, we can then put some stitches in and often close those and get those closed then. I'm trying to think back. I don't think I've ever not been able to close a cleft of the palate. I was recently out in Manila operating on a 22-year-old who had the biggest unrepaired cleft palate I've ever seen. I think it was nearly 1.5 inches wide, and we managed to get it together using those three techniques.
If no one's got anything to add, we can move on to the next question. So someone's asked, my daughter has a microform cleft and we've been told that surgery is optional, so how do we decide?
I'm going to share this one with Amy in a minute, but I'm going to because Amy is a big part of how you decide. So I think the way you decide, first of all, is discuss it with your cleft team. So you need to talk to the surgeon and the specialist nurses and the psychologist on your cleft team. So if a cleft is very small, it's possible that the scarring that arises from that cleft repair might be as obvious as the cleft itself. The difficulty is that scarring is unpredictable. I can do the same operation on two identical babies, and one of them will make a tiny scar that you can't see, and one of them will make a massive red scar that takes ages to settle. So that's the difficulty. I would hope that the surgeons and nurses on your team will be able to give you some advice about the likely scarring, and help you weigh up the pros and cons of that scarring versus the cleft that's left. What I would say is that often in a microform cleft, there's a small gap or a little notch in the lip or some irregularity of the red line, but there's almost always an abnormality of the muscle underlying that microform cleft. And when it's repaired, that muscle abnormality is rectified so that the movement of the muscle is normal, the shape of the nose is improved. And even if the scar looks a lot like the cleft in the first place, the muscle repair has a big advantage in making that lip function and look better. And then the important person to speak to is the clinical psychologist on your team who is going to help you make those decisions. Over to Amy.
Thanks, Peter. So yeah, there's a kind of a decision about whether you want to keep it as the notch or the small cleft, or whether there's a scar, and Peter has given kind of good pros and cons for kind of either option. Then you've got to then think about whether you go ahead with the surgery, or you could go for a kind of a watch and wait option. With that, what you've got to do is think about the best windows of your child's development for having this type of surgery, and whether, you know, Peter might kind of have some comments as well. We know that as children become more mobile, when they're kind of standing up, kind of walking around, cruising around, they're more likely prone to falls, and therefore they might then knock their lip and kind of open any surgery. They're also more likely to start picking at their scar, etc., at that age as well. So there's going to be a window where the post-operative care of the child is going to be a little bit more of a difficult window. I don't know whether, Peter, you would agree with that in terms of kind of that operation. So sometimes that's why a kind of lip repair happens earlier rather than later. It's important to remember that your cleft care should also have, you should have access to psychology. So sitting down with your psychologist in your team is really helpful to think about some of those decisions. We know that kind of visible difference can affect someone psychologically in the future. So it's important to kind of think about how much of a visible difference there will be, whether you have the scar or whether you keep it as the notch. And I think one of the biggest things you can think about is sitting down with someone who might have had to make this decision. There are other people within the cleft community, within Clapper, who will have had to make this decision, and sitting down with them and thinking about what factors they had in making that decision is also an important one to think about. But definitely access the psychological support within your service to think about that decision.
Okay, next question. Our service has quite a long waiting list. We're looking at least 8 months for lip repair before we even get onto palate. Have there been any short or long-term implications or complications from babies having lip or palate repair surgery later than normal?
I'm going to answer that question in backwards ways about, because some things are clearer than others. There is quite reasonable evidence, most of which has come out of Europe, and Europe and the UK lead cleft care in the world. There is no doubt. So palate repair after 12 months is, in a population, so if you have 1,000 babies who have a palate repair at 12 months and 1,000 babies who have a palate repair after 12 months, the group that have the palate repair after 12 months will do worse. That doesn't mean that individuals in those groups will do better or worse. It just means as a whole, the later palate repair is, in general, the worse it is. And in the UK, we would generally accept that. There's been evidence, there's been people in Europe and in other parts of the world who have tried to delay palate repair or parts of the palate repair on the basis of this might help facial growth, which in my view was completely wrong. But that the problem was the speech in general was worse. So, providing you are heading towards a palate repair at 12 months, then that's grand. I think I know there are some services across the country that are doing lip and palate repair together. I've done that in the past. It's not something I've needed to do in Newcastle because we were able to pick up after COVID quite well, but it's certainly possible, and it's certainly something I've done in cleft missions in the third world. And Amy touched on this, and there's been some discussion about lip repair in babies who are toddling and whether they might fall and bash their lips and they might dehiss. It's theoretically possible, and there have been some examples of that. Part of me is less worried about that. I've been out in Manila recently. We've been doing 8 and 9 month old children in the Philippines. They toddle too. I think I wouldn't not repair a lip in a toddler. I would be thinking about doing a combined lip and palate repair at 12 months, or to get it in before 12 months. So the short answer to a very long and complicated question that could be a PhD on its own or involve a whole university department is that providing your palate's repaired before 12 months, grand. And if you can get your lip repair in such that you can get your palate repair in a separate go before your 12 months, that's great. It's when the palate repair starts going, and the UK standard for palate repair that we work to is palate repairs before 13 months of age.
Thank you, Peter. So we've had something through in the comments, and that links quite nicely to the next question, actually. So someone said that my daughter was 2 in April and we've still not had surgery through choice as she has a cleft lip. How do you get through the physiological process of a mum? So, yeah, knowing your child is going to be in pain and there's nothing I can do other than paracetamol, which doesn't seem a lot for the type of surgery. And then the question that links is, I'm very anxious about my son's upcoming lip repair surgery. The thought of him being put to sleep, the pain he'll feel during recovery, and that he'll look so different. I love his cleft lip and I'm worried about it looking different. So basically, is there anything that I can do to prepare and ease these anxieties?
Can I start again, Amy, and then pass
you
on
start,
to you?
yeah, definitely.
So, lip repair. The first thing that I do when I repair a lip is make it numb with local anesthetic. If you were 20 and having a cleft lip repair in India, it's not at all impossible that you might have it mended under local anesthetic. It's numb. There is from the before any pain is inflicted on this baby, this lip is numb, and it's numb not just from local anesthetic in the edge, but it's numb from local anesthetic into regional nerve blocks on the face. The questioner mentioned paracetamol. In hospital, there'll be other drugs available, so sometimes codeine, occasionally morphine, but actually, having looked at a lot of babies who've had lip repair, they are not in vast amounts of pain. What they are in is absolutely, completely bemused, because we all know if you have the tiniest little thing in your mouth, if you've got a cracked tooth or a sore tongue or a little tiny thing in your mouth that you have and it changes, it's weird and it's massive. And these babies have had a cleft lip for 33 weeks before they were born. And then we make it numb, and it's like, you know what it's like when you go to the dentist, your lip's made numb, it feels massive, feels weird anyway, and then we stitch it together. Lots of babies lick their noses through their clefts. I see that all the time. It's a sort of comfort thing. We stop them doing that. We make their mouths completely different. And I've operated on adults with cleft lips, and I can remember a lad who was 24. He had his primary lip repair. He lay in bed, not in pain. He was almost, he couldn't communicate with the world because it felt so weird to him for his face to be different. Now I don't understand the psychology of babies. I mean, I'm sure it does, but if you do that to a baby and their face feels that weird, it doesn't have to hurt for the baby to have some distress. That said, babies want the mum and the dad and to cuddle and to be warm and have the nappy changed and to be fed. And if we do all of those things and give them a bit of analgesia, then they're going to be fine. One of my routines, people worry so much about anesthesia. And the way that people rationalize risk is very weird. Risks that you own are very easy to take, and risks that are someone else's are very hard to take. So there is undeniably a risk to general anesthesia. It's a tiny risk. It's a particularly tiny risk in a specialised children's hospital when this anaesthesia is given by anaesthetists who are giving anaesthetics to babies all the time. So I get asked this question loads. Mums and dads are really worried about the baby having the anaesthetic. They're not worried about me. I can have as many sharp instruments as I like. What they're bothered about is the anaesthetic. And I have a lot of patients who drive from Middlesbrough to Newcastle for their baby to have a cleft palate repair. That is 40 miles along the worst road in the country. The A19 is a dreadful road. It's horrible. The risk of driving your baby to the RVI in Newcastle to have its lip repaired is much higher than the risk of an anaesthetic by many, many, many times. So what I say to mums and dads is, when your baby is in the hospital, it's safe. It's not safe outside. There are things we do with our babies all the time. I suspect that crossing the road, busy road, with your baby in a pram is much riskier than your baby having an anaesthetic, and that's just how it is. So please, I try to reassure people about anaesthesia all the time. It's not the big risk in healthy babies in children's hospitals that people think it is. As regards the change in the baby look like. So when I'm going to let Amy speak in a minute, I am aware that I talk too much. So when I was a junior cleft surgeon, I would do what I thought was a fantastic job. And I'd think, well, repaired this baby's lip, and I'd think I'd done a really good job and it looked great. And I'd go to the mum and dad, and their mum would be crying. And I'd be feeling quite, oh, that's not desperately good. I've clearly not done a good job there. Mum's upset and crying. I now realise that is because mum has fallen in love with the baby with the cleft, and I give them a baby back that looks different, it sounds different, and it smells different. And I've had mums who have drawn secret marks in biro on their baby to make sure they got the right one back. Now that is a bit extreme, but it is like that. What I do see is the shock of and sometimes it is a shock of this baby coming back who looks different, but it soon settles, and you fall in love with your baby all over again. Sorry, Amy, over to you now.
That's okay, Peter, thank you. One of the things I wanted to kind of follow on from when you were saying about kind of babies and, you know, that kind of difference, if they're feeling different in their mouths. Babies and young children are experiencing new different sensations day in, day out, and they adjust to those far better than adults. You know, I know that as an adult, if I've got a pain or I've got something, if I've got a paper cut, it will annoy me for days. But if my child falls over and has a right gash on their knees, within 10 minutes, they're probably up and about and running afterwards, because they're just used to changes. They almost don't see it as pain or a problem. They get over it quickly initially and they move on. So I think sometimes we as parents worry a little bit more about those things, and the kids actually adjust really quickly because they're just used to changes in physiological states. The other point to think about is how very, very normal it is to have those anxieties. As Peter said, there's huge anxieties about anaesthetic in particular. And we've even had parents who are doctors or anaesthetists themselves with a cleft child who worry themselves about that aspect of surgery. So it's absolutely normal, regardless of who you are, to have those anxieties and fears. If we could ask in the chat, I'm sure most people who have undergone these operations will have had really similar fears. And cleft services do recognise that whilst Peter does these operations day in, day out, as do other cleft surgeons across the UK, we do recognise the huge undertaking it is for you to give your babies to us. And I think that's important. And we kind of really respect and honour that, and honour that that's a difficult thing for you to do. In terms of thinking about working on your own anxiety, engaging in self-care is really important. One of the first things that goes when you become a parent is your own self-care. You neglect your own things, but trying to start some practice for self-care is really important. And think about maybe kind of bringing in some kind of aspects of kind of breathing, mindfulness, any of those techniques, so you can employ them and utilize them when you're at those periods of stress at the day of the operation. If you practice some of those techniques beforehand, they might be more readily available to you at the time of the operation. I think most cleft surgeons and most cleft teams and nurses will suggest you take loads of photos of your baby beforehand. It's really important that you remember their smile as it was, but also think about those after photos and maybe get excited about some of those comparison pictures. This was you before, this was you after. And I've also seen some really lovely examples of parents who have created lovely cleft journey books for their child and shown their child with their different photos. So maybe get excited about some of those journey photos rather than worrying about this is what I love now. Think about what you're going to love in the future and the things that you can share with your child. Talk to other parents. They will have experienced similar feelings and worries that, you know, this is his cleft or her cleft and I love it and I'm worried about that change. Remind yourself, as Peter has said, that your child isn't likely to remember this operation, and you know they'll have anaesthetic, they won't experience it. You will have the memories of that operation, but they won't. So try and use that to ease your anxiety as well. If you are having these worries, share them with your family, share them with a partner. These worries are better out than in, and there will be other people within your circle, your support circle that will be experiencing those feelings. And I also want you to remind yourself of the other ways that you love your child. I know you love their smile, there's no doubt about that, but you love their eyes. You love whether they've got an innie or outie belly button. You love how their toes wriggle. Focus on the other things that you love because they won't change. So look for those wriggly toes, look for the innie outie belly button and think about that. And then after the operation, one of the things that you can really think about doing is really engaging with your child and looking at them in the eye. Try not to focus on the cleft. You're going to be drawn to it. You're going to want to see what it looks like and thinking about your reaction. But in terms of how you move on and bond with your child, really look them in the eyes, sing those songs, do those things that you always do to make them gurgle and make them giggle.
Thanks, Amy. I was one of those mums, so I know exactly how that person feels. And the advice about the eyes, that's how I got through it. Looked into his eyes and it was my baby. So I automatically connected. So that was really good advice. Okay, next question. Why are the operations for lip repair and palate repair done at the times and ages they are?
Okay, this is another one of those where there's some evidence and not. So the good evidence is cleft palate, and we've talked about that anyway. Having your cleft palate mended before you are 12 months old is, in general, better for your development of speech. We would all agree that in the UK, most of Europe agrees that. There's still some places that don't, but it's the evidence is overwhelming. There's been a recent study trying to decide whether a cleft palate repair at 6 months or 12 months was better. It was what's called a randomized study. To do a randomized study, the people who are engaged in that study have to have studied the evidence and decided that there was no evidence, no convincing evidence one way or the other. I was one of those people. Newcastle was a big recruiter for that study. The results are out. The results are not very clear cut, and it seems likely that the results might say that it's before 12 months, but after 6 months is the best time. And so strangely, that might be about 9 months. But the difference between 9 months and 12 months is very subtle. So before 12 months for a palate repair, that's grand. And the reason why many of us go for 12 months rather than 6 months when there's no evidence to choose between them is very simple. 1-year-old babies are bigger than 6-month-old babies. Their time in hospital is easier. Their anaesthetic is easier. Their surgery is easier. Everything is easier for them. And if the results are the same, then do it at a time when it's easier for that child. For lip repair, the thing that sets the timing of lip repair is it's just really simple. It's to do it before the palate's mended. So, but after a time when we're sure that the baby's good. So a few years ago, in the UK, in some other countries, there was a vogue for doing lip repairs within a few days of birth. There was some very spurious evidence advanced that that people said, oh yeah, there's some special sort of wound healing that babies, very new babies have that old babies don't have. I've got to be aware I'm on an internet, so can't use the sort of language I might normally use about that. But that was nonsense. But the thing that struck me at the time, and I was a very new cleft surgeon when people were promoting that, was most newly born babies that I've seen look like they've just done a few rounds with Tyson Fury. They look pretty bashed up, and not surprisingly. And why would you want to do a very delicate operation on a baby who's got a really bruised and swollen face? There was when the results were analysed, there was absolutely no benefit of doing what were called neonatal lip repairs. So the big advantage of doing a lip after a few weeks is that the baby's settled, they're over the effort of being born, the feeding is established, they're growing, they're a bit bigger. The rare chance of any congenital problem that they have has been identified, and the old-fashioned timing used to be 10 pounds in weight and what was called 10 grams per deciliter of hemoglobin. So with a blood count that was restored to normal. 10 weeks, it was 3 10s, 10 weeks, 10 pounds, 10 grams per deciliter of hemoglobin. So a 3-month lip repair and a 12-month palate repair is what many of us would do. If the lip repair drifts beyond 3 months, notwithstanding the things about toddling, but most 6 months aren't walking yet, I'm not particularly worried about that. And for a lip only cleft, there is some very, very, very slight evidence that the later you leave it, the better, but it's tiny. And all the disadvantages of going through childhood and early adulthood with an unrepaired cleft lip completely outweigh any tiny advantage of delaying a cleft lip repair, in my view. So that's why we have the timings that we have.
Thank you. So the next question is, why does it seem like some children are having loads of different surgeries and others just need 1 or 2?
Me again, isn't it? So, right, I sometimes say that I have never seen the same sort of cleft lip or cleft palate twice. Now, I've operated on nearly 1,500 babies and young people with cleft lip and cleft palate. I think I've seen 1,500 different ones. So they're all slightly different. There are differences in how big the lip is. There are differences in whether it's a lip and a palate. There are differences between whether it's one side or 2 sides. As we've said already, there are differences in how wide the cleft of the palate is. There are differences that we don't actually understand at all about how children are different, how the clefts are different in ways that are unsubtle. They're very subtle. How different children heal. How different children have different germs that grow in the mouth, how different children feed differently, all sorts of things that we just don't comprehend. There's not impossible that there's a difference between clefts that are on the left side and clefts that are on the right side. It's very likely there's a difference between clefts in boys and clefts in girls that we just don't understand. So it's not surprising that there are some children and young people with clefts who have 1 or 2 operations and some who need more. And the more operations are sometimes to do with problems of healing, and sometimes the commonest reason for further surgery is to help with speech. And a number of children who have a cleft palate repair will need secondary speech surgery. And sometimes that's 1 speech operation, sometimes it's 2. So that's a need. I think that when you get to be a bit older and you've had your cleft lip and palate mended and you've had your gum mended, then different factors come in. And so there are some young adults who are perfectly happy, their lip is good, the nose is good, and there are some some children and young people who say, well, my nose is a bit wonky or my lips a bit irregular. Can you do something about that? My jaws may not fit together in the same way. And then that's an aspect of choice in relation to whether you have another operation or not. And everyone is different.
Okay, thanks, Peter. There's a question that's come through on the chat. My son received his cleft lip and palate surgery in Broomfield. We are now based in the Northeast and will have gum notch surgery under a different surgeon. How will this affect the repair? Will a discussion be held between his previous surgeon and the RVI team, or will the surgery notes and previous photos be used instead?
Okay, well, I am the RVI team, or at least I'm half of it. So this is alveolar bone graft surgery. We're not onto that yet, but alveolar bone graft surgery doesn't undo anything that's been done before. So it's not going to, it may change very slightly the shape of the lip and the nose in relation to the support of the upper jaw beneath the nose, but not massively. And we've done PhD studies on that using 3D imaging. There's a small change, but not big. The lip doesn't get undone. The palate doesn't get undone. It's doing something that you've not done before. Cleft centres in the UK, we're very friendly. We all talk to each other. We talk to each other loads, and there's not many of us. There's only 10 cleft centres, and what happens is when children and young people move from one cleft centre to the other, very often we know that they're moving to us before they do, or before they've got an address, because we've had a letter from their existing cleft service saying, Johnny's moving to the Northeast with his mum and dad, and they're going to be in touch with you very soon. So we share notes really, really well. And so we have notes from the original surgery and all these things. It is just one of these things that happened. It's a really, really good example in the UK of collaborative working, and you know, and there my colours to the mast. I am a massive supporter of the NHS, and it is the best thing of the NHS that we all talk to each other, and it's one service, and we pass stuff around. But if that caller is on, if they've got concerns about that, speak to your cleft service in Newcastle. Speak to your specialist nurse who you will know, or we can put you in contact with, and speak to us when we see you at the appointment.
Thank you. We've had another question in the chat saying that my son has just had surgery on Monday for a repair of a small fistula that's been affecting his speech. How long can it take for the wound next to the gum to heal and close up?
Well, it should be closed. It'll be closed now, but it won't be healed. It'll be held together with stitches. I would generally say that if I'm just sticking my wet finger in the area and trying to think about where the wind's coming from, if it is still healed at 8 weeks, then it is probably going to stay healed. In the meantime, there are some things that you can do to help that to heal. I'm sure that your cleft service will have given you some guidance about what to do and what not to do. Cleanliness is truly next to godliness. We have loads of germs in our mouths, and brushing teeth, and I'm not only saying that because Alex is on the call, but brushing your teeth and keeping your mouth clean and getting rid of the germs in your mouth is really helpful. Having a glass of water after you've had anything to eat, keeping your mouth clean, that's really helpful. One of my big things about fistula closure is do not use a straw. If to use a straw, you've got to create a suction in your mouth, between your mouth and your nose, and it's like if you were trying to test to see whether your fistula was closed or not, you'd try to suck through it. So don't, I'm sure that your team will have told you that. Absolutely no straws. Cup, no straws.
Okay, we've got a couple of comments that's come from the chat. Mandy says, this is also interesting. My son is 6 and has had 6 or 7 surgeries so far. So we've been through a lot of this, but it's very interesting hearing all discussions, the processes, and what these surgeries feel like for the little ones. Thanks for all you do. Another one, I would like to say, my son looked so different when he came out of his lip op. I miss how he looked before his op, but I fall in love with him again. I would just like to say a big thank you to you, Peter. He did a great job on my son. So there you go, Peter.
Very nice to hear those comments. Before we carry on with any more questions, we're actually very pleased to welcome along Will, who is a member of the Children and Young People's Council here at Clapper. He's very kindly offered to join us today for a midway break to share his story about his cleft treatment and his journey. So, Will, would you like to briefly introduce yourself and share your story?
Hi guys, I'm Will. I'm 17 and I'm part of the Children and Young Persons Council at Clapper. And I've been given some questions to kind of answer. So yeah, I'll just kind of go if that's okay. So the first question I've been given is, how many surgeries have you had so far and what were they? So I've had 3. So I've been quite lucky in that kind of sense of I've not had to have kind of loads and loads of surgeries. Obviously I had my lip repair, my palate repair when I was like a baby. And then I had my bone graft in year 6. So I'd have been like 12, I think. And my second question is about these surgeries. What do you remember about them? And like before and after? Obviously, for my ones when I was a baby, I don't remember much, but my mum's kind of told me similar stories to what I think it was Amy or Joanne said about kind of my mum said that I looked completely different when I came out of the womb, but she like a little bit of a kind of like missed like seeing me with like my lip kind of not stitched together. But that's all I can kind of say about that. But my bone graft, I remember very clearly. I actually made like a little 3-part YouTube series on it, like documenting the whole kind of procedure. And obviously I was nervous, like anyone would be. And I'm sure like anyone who's watching, your children will be nervous. But the way I kind of dealt with it was I went in just with like a very positive mindset. So I tried to think about like the good things of one, it would help me. And then the second would be I'd get some time off school. But yeah, so I kind of went into it with a positive mindset. And obviously having the surgery and having bone taken from my hip, that was like, it's a little bit sad at first, like 'cause I couldn't walk and like being able to like having to like be kind of pushed around everywhere by either my brother or my mum was a little bit frustrating. But I was quite happy afterwards. Like it kind of took maybe like a week for me to be like kind of back to my like usual self. But I think generally I was quite happy. Like obviously it was a little bit sad and it's definitely very painful. Like with kind of like the things being put into you. Like I remember I had to have like water kind of being like put into my arm and stuff like that, which wasn't the nicest. But it was, the way I looked at it is it would be kind of a delayed like gratification kind of thing of like, okay, well, it will make things better in the long run. And I think that's kind of, that'd be the main bit of advice I'd give to anyone. And then the third one is, has the time off school affected your schoolwork? Not really. I think like the age it kind of happens is a crucial age for like, I'm sure for like brain development, but actually within like school, you taking like 2 weeks off is what I think I took, or maybe a week. It wasn't really like brutal. It was absolutely fine. I kind of went back and saw all my friends, and that was just the best bit really. It was seeing all my friends again I hadn't seen for ages. Although I took loads of time off sports, which for obvious reasons. But luckily, I'm not a very sporty person, so I was quite happy about that. And then the fourth question I've got is, what are your top tips to share with other young people who have surgeries coming up? And like I said earlier, I think it definitely has to be just go in with a positive mindset. And obviously you'll be nervous, just like I'm sure the parents will be just as nervous. But it is worth it in the long run. So I've got a rhinoplasty coming up soon, hopefully this year, but I am nervous about it, because obviously it's like a very definitive thing of like, okay, my face will look different, but the positive side that I'm taking from it is, okay, yeah, I will look different, and I might come out of a surgery and not recognize myself for a few days, but it will make me kind of happier in the long run, in terms of like, because I feel very self-conscious about my nose, so I'll be like, okay, right, well, I don't have to worry about that now. And so yeah, I'd just say try and find the positives, even if there doesn't seem to be many on like kind of a surface. Just look at it maybe as like in the future kind of thing. And then my last question is, what's been the most useful thing to bring with you to hospital when you've been for pre-ops and surgery? So my bone graft, I took two things. One was like the teddy that I've had since I was born, because I think that's quite a standard thing, especially in the Children and Young Persons Council. It's like that's the kind of a common thing as well, but it's always like, oh yeah, took that. And then I'd say that's like the main thing, but then the other thing was just I took all my favorite foods, particularly custard, because I used to eat a lot of custard then, and that was like very good for surgery because obviously you're not kind of biting down on it. But yeah, I'd say just take something that means a lot to you, and if you've got like an iPad or a phone, maybe take one of those as well, because it gets quite boring if you're sat in a hospital bed for kind of 3 days. But yeah, I'd say those are my, like, well, maybe three biggest things then was bear, iPad, and custard. But yeah, that's those are all my questions. But I'm not sure if any of the kind of a panel have got any for me. But yeah.
That's great. Well, thank you so much. That's been really insightful. And we're so grateful that you've been able to join us this evening to share your story with us.
No, it's okay. It's fine. Don't worry.
Thanks again for your time.
Thank you very much for having me. Thank you.
No problem. Alex and Peter, we're going to go on to bone graft now. So I don't know if one of you can just give us a brief overview. That would be great.
Yeah, sure. So bone grafts are for children and for adults who have got a gap in their gum. The majority of cleft patients only have a gap in their palate. So perhaps maybe around half of patients might need a bone graft, or a little bit less than that probably. And I think it's a big operation because it's important for us to remember that it's likely to be the first operation that cleft patients remember. Often the majority of the operations that are done for infants and for babies, and maybe for very youngsters, and perhaps the bone graft is the first one that patients remember. So I'll try and just do a little summary on what, where, why, and when, and then perhaps we'll take those questions if that's okay. So what is alveolus? Because lots of people don't understand that term, and it's a medical term for the gum. Essentially, your teeth stick out of your alveolus. So the alveolus is essentially the gum. And if you've got a cleft that goes through your gum, then you may well need a bone graft. Not all patients do. Sometimes if you're born with a little groove in the gum, that groove can fill in as teeth comes down and as you grow and develop. So it's not impossible for a small notch in the gum to actually be repaired essentially by growing. But in the majority of cases, you might well find that you need to have the tooth-bearing part of your mouth repaired. So that's the what. The where, well, the where is obviously the cleft is in your mouth. And so the operation is likely to be in your mouth, but also with a harvest site, which is commonly hip bone. And the reason we tend to use hip bone is because it's a big bone and there's plenty of bone inside it that we can steal, and actually that won't make any long-term impacts to your hip, but it has got great potential to heal up and become useful bone in your mouth, in your gum. So the why do we do it? Well, we really do it for several reasons. Some are quite firm reasons, some are a little bit soft, and Peter alluded to some of these earlier. We do it mostly to allow the teeth to come in, and usually that's the second adult incisor or the canine tooth, so the number 2 or the number 3 tooth in the upper arch. We also do it to try and improve the anatomy and the support that you're likely to have around the teeth at the top of your mouth. We do it also to block up any last remaining holes that might be still there. And as Peter said, we do it to try and support the base of the nose and to make the jaw into one piece. Those are sort of secondary or even tertiary benefits rather than anything specific. So when do we do it? Well, a cheeky answer from somebody with a dental input is that we do it when you're toothbrushing and your oral hygiene and your dental health is good. Hopefully that is at the optimum age, so that we're not waiting for you to get your toothbrushing and your dental health good before the operation, and that delays the operation. We would really hope and expect that your dental health should be good so that we can provide this treatment roughly 7 to 10 years of age. Everyone's different, and you heard earlier that perhaps a little bit older for some people, a little bit younger for others. It depends on really your dental development. It's the dental development that times when the bone graft is right for you. I thought also it'd be useful to know a little bit about when has the bone graft been successful. Well, it's been successful if it meets those objectives that we talked about earlier, if it allows the teeth to come through, if it supports the anatomy around the teeth, if it blocks up any holes, and if it supports the nose and makes the jaw one. But really what that means is that we would check it at about 6 months after the bone graft surgery has been done, and we might check it with x-rays in the same way that we do when we're assessing the timing for bone grafting. And then just some last points. In preparation for bone grafting, some patients might benefit from braces, from some orthodontic treatment. But actually, it's really interesting. In my career, when I started this 20 odd years ago, pretty much 95% of patients would have benefited from orthodontic treatment before their bone grafts to get their top jaws into a shape that would be conducive for that bone graft surgery. But actually now this has really changed, and it's actually something that I do so little of because of the fact that the primary surgery, the initial surgery that the surgeons are doing for babies, that surgery is now so good that often we don't need to do the orthodontic setup for bone grafts anymore. The patient still might benefit from the bone graft surgery, but they may not need the braces to prepare them for that. So that's something that has changed a lot in my time. And then just a few do's and don'ts around the time of your surgery. Do brush your teeth. That's crucial. We want your teeth to be clean and healthy. And you've heard your mouth is full of bugs, and those bugs are just waiting to have a party in your new operated bone graft. We don't want that to happen. We want your bone graft to be a success and for you to only have it done once. So oral hygiene is super important, and you'll certainly get some advice before and after your bone graft to make sure that you're onto that. And then a little bit about, a little bit similar to the palate surgery, don't suck hard on a straw or blow up a balloon or anything like that that changes the pressure in your mouth, because in the same way as you can make holes through a palate that's just been repaired, you can also do the same through a bone graft that's just been repaired. And we might be a bit harsh on you and say, please just avoid really hard, crunchy, crispy, spiky foods. So stay on the soft stuff. We love the custard idea, although maybe if it's sugar-free custard, do they do that? I don't know. But that sort of thing, you know, soft stuff is really good. Stuff that's got calories in it to make you feel good, to help you repair your surgery, but stuff that's also good for your teeth. And also, we might keep you off games for a bit. So we might just delay your return to sports just a little bit. So that's a little overview. Happy to take any questions.
So there is a question that's come through, and I think you did touch on it, Alex. With bone graft surgery, why is the bone taken from the hip? Is there the possibility to harvest cells from the umbilical cord to grow into bone cells due to their pluripotent stem cell, I don't know if I said that right, I do apologize, nature, possible research and trial in the future?
I wonder if one of my registrars has posted that question for us. So why is bone graft surgery taken from the hip? Why is the bone taken from the hip? The hip's a big bone. It's got lots of the soft, mushy stuff inside it that we use to, or surgeons use to restore the cleft in your mouth. You can take it from other places. There are other donor sites on the body and maybe even on the shelf. But actually, probably your hip is the place where you get the most bone from, the highest quality bone, and hopefully, therefore, that reduces the chances of needing this treatment done more than once. There are options for using synthetic bones. That technology is not new. It's probably 10 or 15 years old and maybe a bit more, but there are developments to that. And yet still probably the best solution comes from your own bone. The clever words there, pluripotent stem cell. A stem cell is a cell, it's a sort of mother cell, if you like. It's a cell that can produce all sorts of different types of tissue. And they live in lots of different places in your body, particularly in your umbilical cord, so the cord that connects you to your mum as a baby. But bizarrely, they live inside baby teeth, but they also live inside your bone marrow. And if you're taking bone marrow or you're taking the inside of a bone, you're also going to be taking some stem cells. I reckon, and Peter, you probably can comment better on this, but at some point way down the line, maybe we'll be growing stuff that is yours in a laboratory before your operations and then grafting that into you, but that's still quite a long way away yet. Peter?
Yeah, I think that even people as old as me have pluripotential stem cells circulating in our blood, which is an astonishing concept, but it's true. Bone grafts take because of some of the cells in the bone, but actually bone grafts mostly take because the stem cells that are circulating in the blood look at the bone graft you put and go, well, hey, this looks like a good place. This is a nice home. It looks a bit like bone. There's no other cells there. We're going to live there. Sorry for that, but that essentially is what they do. Circulating stem cells, circulating bone growing cells populate the bone that we put in. There are bone substitutes. There's one that I use really commonly in adult patients, and I know that it turns into bone because I've sampled it and it becomes bone. I think that part of the issue, I think that Alex might be hard to persuade to move a tooth into a piece of artificial bone in a bone grafted site, because if you move in a tooth, which is what Alex does, Alex is brilliant at moving teeth. He can move them anywhere pretty well with braces, but not into somewhere where there's not a really good blood supply. And that would be the big worry, I think, about bone substitutes. I think the future's there. I think in whoever follows on from me, the next generation, I think, will have bone substitutes that work and are effective, but we've not quite got them yet.
Thank you. So the next question, I think, Alex, you may have already answered this one as well, but the next question is, what support and follow-up is available after ABG surgery?
So yeah, so from an oral hygiene point of view, we would be seeing patients at some point after their operation, not just to see that the wounds are healing up and that the patient is doing okay. There are various sort of inputs from our clinical nursing team and from our psychology team, and I guess various services look after patients in slightly different ways, maybe from a wholesome point of view after their operation. But we're not really going to do anything active from a physical point of view for some months after their bone graft surgery, because we want everything to settle down, we want everything to heal, we want the bone graft to have the best chance of working as it possibly can do. And if you imagine you broke your leg your leg would be in plaster for 6 weeks, for example. And so we want your gum, your mouth to be quiet for that kind of time, to enable the bone to knit in and to heal up nicely. So that from a non-psychological point of view, that's kind of what we're doing. But Amy, I'll perhaps pass to you if you want to add anything else.
Yeah, of course. In terms of kind of, the follow-up after ABG surgery, different cleft centres will have different options. You probably will have a fairly immediate phone call from the nurse. There's, in terms of when you're still in hospital, there's some excellent play specialists across all hospitals in the UK who will engage with your child, keep them, occupied, distracted, give them things to do and work with them on that. And I think that's really important. They will have follow-up care. Different centres will have different follow-ups with MDTs, so you'll have that contact. You'll obviously have your named nurse as well, so you can contact them for anything. In terms of psychology, as Will was saying, he sounded like he bossed his ABG surgery, and he kind of went in with the attitude and came out. And most of these surgeries, kids are so resilient and just handle the surgeries really well. Often it's the parents that worry more, and the kids can just fly through it. So we don't ordinarily put psychology access in immediately afterwards, because actually there's a natural time just to process it and recover and go through, etc. But if there are longer term consequences, or if the child's worries, or there's been something that has happened that makes the child kind of worry about future surgeries or the experience that they had, then psychology can certainly get involved. But we wouldn't ordinarily jump in at that point, because you'll just have the recovery time post surgery, and hopefully you'll be feeling like Will did, this was worth it and it is great.
Can I just make a sort of general point, which is sort of applies to pretty much every question that we've had, but it's certainly this one. And we in the UK, we have the best cleft service in the world. I have no doubt. It's possible that Norway and Sweden are as good as ours, and they were certainly better than ours before, but I don't think they are now. That means that every cleft lip and palate patient in the UK has access to a cleft team. The cleft team has cleft specialist nurses. The cleft specialist nurses were the biggest important improvement and change to cleft care when that all changed in 2002. Cleft specialist nurses are great for the mums and dads when they're babies. They're also there for the older children. Our cleft nurses go and see the adults when they've had their rhinoplasties. They go and take the splints off. One of our cleft specialist nurses is now occasionally looking after the babies of parents who she also looked after when she was a cleft nurse. This is continuity of care. You've got a number, you've got surgeons, coordinators, access. We're only ever a phone call away. And certainly the nurses are very, as Alex says, the nurses are very available. And that's these questions that we've had tonight, ask your cleft team. That's what they're there for. It's our job.
Thanks, Peter. Right, we're going to go into jaw surgery. And I don't know, Alex, do you want to
could I just say really quickly, so there was something about the gum repaired at the same time as the lip and palate, and the reason it's not done is that it's bad. Don't repair babies' gums, it doesn't work. Sorry to jump in, but just in case someone was after that one.
So we're going to go into jaw surgery. Alex, do you want to give a brief overview, please?
Yeah, of course. So jaw surgery is an option of treatment. It's not something you have to have done. It's something that you would be offered if it was appropriate. Again, we want your teeth to be super clean and healthy. That's a sort of prerequisite, because most often jaw surgery will involve some orthodontic treatment beforehand, some braces to prepare you for that jaw surgery. When do we do jaw surgery? Well, we would assess you probably in your late teens, 16-ish is kind of the earliest we would start thinking about it. And perhaps we would then lead you into orthodontic care, so that we would perhaps deliver the surgery when we think that you've stopped growing. And that would normally be at 18 years of age. And I say that as the earliest time that you might consider jaw surgery. There are plenty of older and adult patients who come back to services later in life, and we've certainly done jaw surgery for patients in their 50s and older. Probably it is easier for you to manage as a younger person than it is as an older adult. One, because you're fitter and you get over things better. But two, I think also you've looked in the mirror every year of your life and your face has changed that little bit as you've grown and developed. And so one last change when you're a teenager is probably easier to manage than when you've lived with your face for 30 or 40 years or whatever it might be. Why do we do jaw surgery? Well, we do it just to help the balance of the face. So from an aesthetic viewpoint, we would like to see harmony as much as we can, so that one jaw isn't more prominent or less prominent than the other. And for cleft patients, it's often that the upper jaw is less developed than the lower. So that perhaps gives the lower jaw a more prominent look, and maybe the upper jaw a slightly more recessive look. We would work you up through the process to determine whether or not you did or didn't want to have jaw surgery. And ultimately, we hope to be able just to give you the information that you need to make your decision as to whether or not you would or wouldn't go ahead with jaw surgery. And like all sort of operations, there are risks and there are benefits. The risks are mainly to do with sensation of the face, but also to do with the quality of your speech. And so you would be worked up through a process looking at your speech and whether or not there would be operations and impacts that potentially you might open yourself up to after you'd had the jaw surgery. Because sometimes bringing your top jaw forward can affect the way that your palate functions. So there are things, pros and cons, there are things to consider, but like all things in life, there are usually solutions for them. So our aim is to help produce a more balanced face, a face where the teeth bite together nicely, and a face that doesn't have any significant negative impacts from this sort of treatment. As I say, you need orthodontics, you need braces to set you up for this, and that brace process is usually 2, maybe 3 years long, with the surgery around about 2/3 of the way through that process. That's a kind of brief overview. I'm happy to take questions.
I mean, I think the question that we've had about this surgery actually have kind of answered it pretty well. But in case there's anything else you want to add, we've been asked, so I've been offered jaw surgery and I'm trying to decide if it's worth it. What's the likely recovery period and the likelihood of needing further surgery?
It's a really specific question for an individual, which is tough to answer without knowing the full clinical picture. I guess there is never any pressure to make a decision about jaw surgery. So if you definitely don't need to make that decision in the clinic, but absolutely our clinical psychology team are really helpful in making or helping you to make complex decisions. And so it's absolutely crucial that you do chat to them, to your friends, to your peers, and potentially look at all sorts of patient information that's out there. The British Orthodontic Society has a fantastic website called yourjawsurgery.com, and that has some video diaries of patients going through jaw surgery. Not any cleft patients, as it happens, but certainly patients with a similar kind of problem that cleft patients have in terms of the type of surgery. And yeah, it's well worth investigating that site. But Amy, you probably want to come in here, and I think it's absolutely crucial that your team are involved.
Thank you, Alex. Yeah, we do have national guidelines that suggest that psychology should be involved at all stages of that jaw surgery journey, from deciding whether to do it, so kind of pre-op, that decision-making process. It's major surgery, it's elective surgery, but it does need careful consideration. Also kind of like thinking about preparing for surgery and post-surgery. So psychology is always involved at all stages of this journey in particular. And as part of that, psychology will help you consider, what is your current mood? What are your current anxieties? How do you currently cope with things? How do you cope with pain? How do you cope with other things in general? That's important to consider, because you are going to be undergoing major surgery. So you need to think about how you kind of cope generally with those kind of things. You need to think about the support that you have from friends and family, because you will need kind of help in terms of that recovery recovery, that kind of post-surgery? And how have you coped, and what are your experiences of previous operations? Do you have any anxieties from previous kind of medical appointments, medical operations that might need a bit of work on? You'll also be asked some questions, you know, in terms of what is your understanding about what the surgery? Alex has done a great job of explaining what the surgery is, what the benefits, but also the risks of that surgery are. So it's really having a chat with you about how much you understand about that and understand the impact of the surgery. And it's also important to think about, are you prepared for the questions that you will have post-surgery from friends? You will have comments from people, you know, it'll take a while for your face to settle down post-surgery as well. Have you talked to your friends about it? Are they aware of that? How will you react to any comments that you might have from people? So that's really important to think about. And you've also got to think about what you think the impact is going to be, other than changes to your physical appearance. Do you think it's going to change how you feel about yourself socially? Do you think it's going to kind of enhance your well-being in other ways? And we need to think about whether you've got a realistic understanding about what the surgery can change in your life. And also really consider the timing. You know, have you got exams coming up? Have you got a gap year? Have you got any social events coming up, etc.? Because it's major surgery and it takes a while to recover. So you need to think about the timing of the surgery. We do know that there's lots of psychological benefits that have been seen from having this type of surgery. There's lots of report of increase in quality of life, greater satisfaction with your appearance and self-confidence, and a real positive impact upon self-esteem and social functioning. So we do know there's real positives to that, and it's weighing those up against the risks that Alex talked about.
Thanks, Amy. There was a comment brought in from the group, and it says, I'm not sure if this is helpful at all for oral hygiene, but I had some little pink pills I could crunch, and it highlighted where I wasn't brushing my teeth so well and encouraged me to rebrush. It was quite fun for me as a little girl, and I noticed my dentist sells them. I remember those when I was little as well, actually. So that was a comment.
That's music to my ears, those things. I push those like something I shouldn't be pushing, but it's really, really good for patients to be able to see where they're missing, because often, you know, plaque is a tooth-colored substance and you often can't see it. And those little vegetable dye tablets are a good messy game for youngsters. In fact, I often encourage whole families to do it, and they can have a little comparison of who's got the cleanest teeth. But it certainly helps you to see where you're missing and to help learn good new techniques to make sure you stay with clean, healthy teeth all the time.
So the next question is on rhinoplasty. Peter, do you want to give a brief overview, please?
So rhinoplasty is an operation it comes from plastic change, rhino nose, like rhinoceros. So rhinoplasty is an operation to change the shape of your nose. Rhinoplasty, for people who've had a cleft lip, is said to be one of the harder sorts of rhinoplasty to do. In general, in the UK, mostly cleft rhinoplasties would be done by cleft lip and palate surgeons, not general rhinoplasty surgeons. They can be done, there are two sorts of rhinoplasty: closed, which is where the nose is changed through cuts inside the nostrils, or open, where you add in a little cut across the base of the nose, where it's called the columella. So the skin of the nose can be lifted off, the shape of the nose can be changed, same for the nasal skeleton can be changed, then you put everything back, so it leaves you with a little scar on the outside. People who've had a cleft lip often have some weaknesses of the skeleton of their nose, so we sometimes need to put things in. Often that is cartilage from deeper in the nose, from the nasal septum, but sometimes it's rib, and I use rib to support the nose really quite often. Very occasionally it's ear cartilage. Very occasionally it's bone, but bone doesn't work. Your nose is not made of bone, it's supposed to be floppy, so rib, which is a bit floppy, works better. It's a general, almost always in the UK, it will be a general anesthetic operation. In the United States, it's done at a local anesthetic, which scares me to death. General anesthetic, often a day case, maybe a bit longer if there's rib involved. Often you have to wear a splint on the outside of your nose. I'm very conservative, and if it's me, the splint stays on for 3 weeks. And sometimes little tubes or a pack up your nose to help support the shape of the nose.
Can I just shout out here a little bit, maybe, that it'll be ideal if making decisions around nose and jaw, if possibly the jaw surgery could happen first, especially if you're thinking about the sort of skeleton, the foundations of the face. The top jaw is the foundation of the nose, and so if you're thinking that you'd love a rhinoplasty, it's definitely worth knowing whether or not you want to or don't want to have jaw surgery before you have your rhinoplasty. You can definitely have a rhinoplasty without having jaw surgery, but if you're going to move your top jaw, it probably makes sense to move the top jaw first and then have the rhinoplasty secondarily. Sometimes you get some sort of free benefits to your nose from moving the top jaw. It can kind of lift the tip up a little bit, and it can increase the nasal projection, but equally it may be that you need, or you might want to consider having that rhinoplasty surgery after the jaw surgery anyway.
Before we move on, we've just had a really lovely comment actually. So Tracy says, just want to thank you all for everything you do. My daughter was born with a bilateral cleft lip and palate. She's just had her rhinoplasty and her confidence has grown so much. We're looking forward to her prom this Tuesday and to the visit to her clinic now her exams are over with. That's lovely.
Very good.
So now
can I just shout one more shout? Sorry,
yeah,
I'm just jumping in a bit.
All right.
One thing that we often say to patients about when they're thinking about these treatments, because there's no question that as you get older, life gets busier. And that's true, particularly for teenagers with exams and year offs and universities. And all of the treatments that we've just been talking about in this last section happen in that busier phase of life. And I'm sure, Bronwyn, you probably remember this in your situation. And often patients say, oh, I'm going to take a year off because I want to try and get my jaw surgery done in that year. And I would really say, do a year off because you want to do a year off. You've got plans to go traveling. You've got plans to do something. Trying to pigeonhole your treatment into a confined space usually, sadly, only leads to disappointment because we don't always meet those deadlines. That might be because you're not physically ready for the operation during your year off. It might be that some delays beyond our control happen. You know, COVID happens. Something happens that delays your ideal plan. And as much as we want to try and make life as easy as it can be for you, the worst thing for us is when we have a disappointed patient because we don't meet a deadline which perhaps isn't a realistic one. So if you're going to go traveling, go traveling. You can go traveling with your braces on, take your disclosing tablets, please, take your toothbrush, please, but go traveling. Yeah, we can tie your brace down a bit so that it's not, so it's it doesn't need a lot of adjustment, so it's as safe as it can be whilst you're away, so that you don't need the elastics changing and that sort of thing. So we can do things to enable you to do what you want to do as in the formative time of your life. So do those things and try not to let your treatment hold you back, but know that we're trying to make your treatment happen for you to fit in with your life.
Yeah, I'd 100% agree with that, to be honest, because I know before coming to university, I was wanting this last surgery out the way before I came. But sadly, because of COVID, there's such a backlog. I've not been able to, I've still not had it. Finished my first year of uni now, and I'm so glad that I did go to uni, didn't take a year out, because now I finished this first year and I'm still waiting for it. So 100% agree with that. Yeah. I think that was kind of it for rhinoplasties. So if we go on to talking about...
Could I make a little comment about kind of rhinoplasty in terms of kind of thinking, it's important to kind of have that conversation with your surgeon and the psychologist in terms of what your expectations are of that rhinoplasty and whether they're realistic. You know, the surgeon will be able to tell you what's possible, and you can have a chat with the psychologist within the team about whether that will make you feel what you think it will feel once you've had the surgery. And you've got to also think about, you know, how you will feel if it isn't the desired outcome as well. You know, we've talked about other surgeries where sometimes the outcome isn't as desired, and you're allowed to feel angry, you're allowed to feel upset, you're allowed to feel frustrated and let down about some of those things. It's important to kind of those, if that does happen, share that with the cleft team, because I think that's important for them to kind of think about, and then you can kind of resolve that and think about that. But I think what you've got to do is think about, again, people commenting about your, you know, yourself post surgery, and how you're going to cope with those kind of post rhinoplasty comments that you will have, because even if they're positive comments, they're still drawing attention to your nose and your face. And if you're already self-conscious about those things, or you're struggling with social anxiety, sometimes even positive comments can create a self-focus and increase that kind of social anxiety that you might be experiencing. So if you are suffering from social anxiety, I would get in touch with the team psychologist and get some strategies to work on that first before these surgeries.
Is there anything else anyone wants to add about rhinoplasties before we move on? Great. So if we're thinking about speech surgeries, then I don't know if Peter, you want to maybe talk about that one, just a bit of an overview of it?
Yeah, so speech surgery is for some children and adults with cleft palate whose speech remains affected by the cleft. So the first thing that you have to do is identify there's a speech problem, which is normally done by the cleft speech and language therapist, and then you have to work out how to fix it. The way that there are two principal ways of working out what to do. One is with doing an X-ray, a talking X-ray. So you've got to be old enough to stand still and talk to command in front of an X-ray machine. So you can, there's a very occasional 3-year-old that'll do that, but usually going to be 4 or 5. The other way to decide that some people use, I don't tend to, is to look up the nose with a telescope while someone's talking. It's a very tiny telescope, but you've got to be robust enough to stand there and have someone look up your nose with a telescope while you're talking. So that doesn't happen to tiny children either. Where there are essentially 3 particular things that you can do, and most of us tend to have an order, but it's given by the results that we have. The first thing we do is called an intravelar. So this is basically where we redo the baby operation, taking particular care to move the muscles of the palate further back so that it lifts more effectively. And another operation is called a pharyngoplasty. There are 2 sorts of pharyngoplasty. Most people in the UK will tend to do what's called a sphincter pharyngoplasty, usually a Heinz pharyngoplasty, which is where the muscles on the back of the throat are built up so that the space that the palate has got to close to is smaller, and that can help. Occasionally people will do a pharyngeal flap pharyngoplasty, which is a way of closing the gap between the palate and the back of the throat by stitching the 2 of them together. The last sort of group of operations are operations that lengthen the palate. So that's often called buccal flap surgery. So we can take tissue from the inside of the cheeks, split, divide at an operation the join between the hard palate and the soft palate, and put the flaps from the cheek in like a gusset, so it pushes the whole palate back and makes it longer. There's a bit of a vogue of people doing that earlier. It's often an operation that I've done for older children if the other operations have failed, but certainly some people do it early as the first operation. So it's those 3 broad groups of speech surgery. Starts with there being a problem.
Okay, thanks, Peter. I've actually got a question, a personal level, for my son. So my son, as I said, is 16 with a bilateral cleft lip and palate, and he's always had a speech impediment, and he used to go to speech therapy, but he took it in his own hands to stop because he didn't enjoy it. It wasn't enjoyable, he said. Didn't want to do it. So he has got lazy with his speech. The speech therapist said that he's quite capable of speaking properly. My concern as a parent, as he gets older and he hasn't changed, will this cause him a problem in the future if he does go back to speech therapy?
I'm going to go a little bit off piece because you probably need to be a speech and language therapist to answer this, but I will do my best.
Thank you.
Right. So if he's having speech therapy for it, this is a speech concern that is not surgically fixable, I'm guessing. The most important factor that says how well speech and language therapy is going to work is engagement. And it's engagement to do with identifying how it's going to benefit you, because it's a hassle. You've got to practice. You've got to go and see a speech therapist. Although they're all lovely and it'd be nice to go and see them, you've got to go regularly. And if you can't see the benefit, then with the best will in the world, you're not going to do it. In general terms, the younger you are, the more flexible your speech is, and the more likely you are to pick up things quicker. But if people decide that they're going to undertake speech therapy in later life, they have the application to do it. They may well just have to work harder at it, and it may take longer.
Thank you, Peter, because I know it's off-piste. So
there's probably some speech and language therapists on the call who are going to phone up and say he's talking absolute rubbish, but I think that's
I'll let you know the comments that come in then. Returning to surgery as an adult. So how do I start my journey to a successful surgery as an adult returning to a cleft care? What surgical options might be available?
This is a big one, and it gets discussed over and over at the Cleft Development Group, which is the committee that oversees and coordinates cleft care across the UK. And there is in general a uniformity of opinion, but a difficulty in how that opinion can be implemented. And I'll speak for me. And I'm aware it's different in some parts of the country, but the big question is whether you can self-refer, and that's a big issue. And I know Clapper and many people in Clapper are very keen on self-referral. I think in general, self-referral is difficult, and there's some problems with self-referral to do with the way the NHS is funded that we just cannot get out of. For me, if anyone in the Northeast feels that they might benefit from having been seen by the cleft team, they can contact us. We will be very supportive and guide them to their GP or their general dental practitioner, and we will support them to seek a referral to us. We will need a medical referral or a dental referral. And then if you are a returning adult in Newcastle, you will see the entire cleft team or a subset of who will discuss with you what it is that you want, who might even identify for you that there are things that you'd not notice, like really your speech could be better. And then the process starts. There is funding in place for adult cleft surgery, that it's not disinvested. You can't go along to your GP and say, I think I've got a bump on my nose. I've got that because my mum had that and I don't like it. Please, can I have a cosmetic rhinoplasty? That ain't going to happen. But if you have a nasal difference because of a cleft, it's going to get funded. The problem arises in that some cleft services are relatively oversubscribed, and for reasons that are a bit hard to explain, patients gravitate to them rather more than to some of the other services, and some of the other services are so up against it with looking after the children that they just don't have the resource to look after adults. And that's obviously wrong, and it should be better. But we can't fix everything. So that long answer to a short question: you start your journey by going to your doctor and saying, I was born with a cleft lip or cleft palate, and I need to see the cleft team and consider what options I have for treatment. And your doctor should refer you to your local cleft lip or cleft team. Every cleft team has an adult clinic. It's there. Everyone has one. Might be a wait for it, but it's there. And the surgical options that are available, reading the question, depends upon what you need, or what you want, and whether what you want is what can be done, and whether when you've discussed with Amy and her psychology colleagues, whether actually you're going to get out of what's done to you what you think you're going to get out of it, and the process is not going to be so bad that it's not going to be worth having, and stuff like that. It's a very individual discussion.
I was about to say the same. It's kind of important to explore that with the psychologists in the team as well. They can explore your whole cleft journey, because there might be kind of things from your, cleft surgery history that you might want to explore. You might have had challenges. Surgery has changed a lot over the years. Peter would be able to kind of reflect on that, but we probably don't have time for that tonight. But there's advancements in surgeries and changes that can be made, but you might want to just reflect and take time to think about your cleft journey and think about whether actually and whether you can think about accepting where you are, or whether the changes that you think or you hope could come from further adult surgeries are kind of realistic and within your expectations, and would solve the things or the problems that you've come with, because it might not be the fix that you're expecting, and psychology can help you explore that.
Thank you. I think the next question may have partly been answered already by Peter, but I'll ask it in case anyone was wondering about it. So someone said, I'm 43 years old and would like some advice on reconstructing my nose and lip. Can I have surgical help without going private?
Starts again with a referral to the cleft team. They will discuss with you your concerns and will examine you to look at the physical problems that you have and give advice to you, just as we've said, weighing up the pros and cons of the surgery that's available. I don't, clearly from where I am, 43 is just being a youngster. The oldest patient that was referred to me was 82. She had been unhappy with her cleft lip scar for 75 years. And I was very happy to offer her a revisional surgery to her lip. She was medically sound, she was psychologically capable, she knew what she was going to get out of it. We were going to do it, but her family talked her out of it. The family said she was a silly old lady and she shouldn't put her health at risk by having operations under my care. And that was a shame, because obviously she wasn't going to live for another 80 years, but I think that the concerns that she had would have been helped. So I don't have an age limit. I don't think there is an age limit. There are some things that don't work well when you're older. I don't think jaw surgery is not great when you get certainly into your 50s and 60s. If you have a structural speech problem with your palate, the chance of fixing that if you're in your 40s and 50s is low, not impossible, but the results may not be as good. And there's things to do with the way the nose particularly is different when you're older than when you're younger, that makes it less easy to heal and change with surgery. But it's just all considered, and it starts with a referral to your cleft team, and I think anyone will be listened to fairly and appropriately and genuinely.
And the next question I think ties into what you said as well, Peter. I'll read it out. Can I have any more surgery on the NHS? I was told 30 years ago that I had no more surgical options.
Well, it might be that there are no more surgical options. People sometimes come to me wanting something, and I say, well, only Harry Potter can give you that, and I don't have a magic wand. Not everything is possible. Very definitely not. However, over the last 30 years, attitudes and techniques and things have changed, and it's possible that what I or my surgical colleagues could achieve now. We might think that we could achieve something that perhaps 30 years ago wasn't achievable. But it's about, again, it's the same answer. It's an assessment of the problem by the entire cleft team, a discussion with the patient about what's possible, what isn't possible, and then what the benefits are of that versus the downsides of undergoing surgery.
Thanks, Peter. So this is the last pre-submitted question, I think. And someone said, I'm in my 50s and I've not had any surgery since I was a child, and I'm anxious about my upcoming operation. What support is available to help me?
And that's probably a question best addressed by myself. So, you know, all teams have access to psychology, so you should be able to access the psychologist. So what they can do is, again, look at your kind of cleft journey. You know, is there anything about previous surgeries that kind of cause you some anxiety or that you remember in a difficult way? So exploring your kind of past experience of your cleft journey would be important. And then they can help you identify what it is about surgery that you're anxious about. What is causing that anxiety? Is there a worry about needles? Is there a worry about medical settings? Is there a worry about the anaesthesia? Are you worried about the post-op recovery? Do you have enough support around you to kind of manage after those surgeries? So what is the best advice is to get in touch with the psychologist within the team. They can really sit down with you. Anxiety is a really complicated and unique thing. We all experience it in slightly different ways, and there might be different things that we can use and different strategies that different people will adopt. So meeting with your psychologist to kind of really think about how it's impacting upon you individually and the different strategies that might work for you would be a really great help.
Thank you. So I think that's it for the questions, unless anyone's got anything to add to that last one. No? But there has just been a few comments that I think would be quite nice to share before we bring things to a close. So someone said, when I was a youngster, I've never had any psychology intervention. It's heartwarming to hear that this is part of the journey for people now. Another comment says, this session has been invaluable. Thank you to all who gave up their time this evening to deliver this. And one more. I'm currently pregnant and my baby boy has been diagnosed with a complete bilateral cleft lip and palate. It's not a question, but I just wanted to say thank you for running this live, as I found it so helpful in trying to understand potential future surgeries and interventions. The impact the diagnosis had on our anxieties as parents has really been overwhelming. So being able to hear all of the information tonight has been so helpful. So thank you again. That's lovely. Thank you so much.
Can I just make a little plug for the film that Newcastle did that is on the Clapper website, using the first few hours? I think that Clapper has a full version, which has got lots of discussions by parents at the end who were pregnant, who had antenatal diagnoses of clefts. I would hope that any parent or parent-to-be would find that film still useful. It's a little bit old, and I had much more hair when we did it. But I think it's still valid, and I would point anyone to that. It's on the Clapper website. He's in the first few hours.
Yeah, I've seen that. It's good. But yeah, I think that's all the time we've got for tonight, I'm afraid. Thank you so much to Alex, Peter, and Amy, Will and Joe for giving up their time to talk to us. It's hugely appreciated, and I'm sure everyone watching at home feels the same as well.
And a bit of a big thank you to you, Bronwyn, as well. Thank you as well to everyone who joined us online. This video will be available by Clapper's Facebook page straight away, and a subtitle version will be posted on the Clapper website as soon as possible. If we didn't get around to answering any of your questions in the chat, remember you can get in touch anytime at info@clapper.com, where Clapper staff can help point you in the right direction. We hope you've enjoyed the Q&A, and that we'll see you again at one of our up and coming online events in the future. From all of us, good night, and I hope you have a lovely rest of the week.